All right. My name is Brus Layson. I'm here with Ray Butts, both with Torrentia Medical Education, and today we are talking all things tendons. So, how we feel about talking about tendons, Ray?
All I want to talk about is tendons.
I mean,
No,
it's
I'm all
nothing.
about it. Tendons are my favorite. I mean,
It's
anytime
something to
you're
see.
connecting muscle to bone, I mean, what could be better?
Okay. Let me ask some questions, and in particular, this is some questions we've had in the tribe quite a bit, as well as I've had some students reach out to me, and as well as to you. Um, What's the literature show right now in terms of kind of the regenerative medicine world and tendon repair?
Yeah, so I often get that a lot during courses as well, and it's kind of a loaded question, right? Like even among the physicians, there's always this question of, well, what's the best thing at this point? Should we be thinking PRP? Should we be thinking adipose-derived stem cells? Is it all about BMAC at this point? I mean, if we're really being honest, I would say that, the most robust evidence that we have is really PRP. I would say that at this point, and this is really across the board, that, adipose-derived stem cells and BMAC are not really conclusively better than PRP, right? And if you're really comparing stem cell injections, this is an even more heated conversation, but either guys fall in the fat camp or they fall in the BMAC camp. What's interesting about that is many of the adipose-derived stem cell guys, they like to talk about how there's a lot more mesenchymal stem cells in adipose tissue as compared to bone marrow. So how many do you really expect to find there? Well, it's really 1 to 5% of the total number of nucleated cells in adipose in fat tissue, whereas it's 0.01 to 0.5% of the total number of nucleated cells is the number of mesenchymal stem cells that you would find in a BMAC sample. So, just with those numbers, you're thinking, wow, so pretty much what you're saying is that there's about 100 times on average more mesenchymal stem cells in fat. So obviously, if I could have 100 times more stem cells, I would take the fat. So it is a reasonable argument until you consider that. Remember that those percentages that I gave you are a percentage of the total number of nucleated cells in that tissue type. And it turns out that there's about 100 times more nucleated cells in BMAC as compared to fat. So if you do the proportion on that, like proportionally, what that means is that it's roughly the same number of mesenchymal stem cells in both tissue types, right? So, to say that one has more, I think is a little bit of an unfair argument. Now, I do think that there are some advantages and disadvantages of where you're getting these mesenchymal stem cells, and I think that kind of depends on the tissue type that you're treating, right? So one of the big examples, or one example of why fat stem cells can be important, is that oftentimes when they do adipose-derived stem cells, they will combine it with a PRP injection. So they break the stem cells out from the fat, they mix it with the PRP, and then they inject everything together. And the reason why that can be really advantageous, especially when it's soft tissue structures like muscle, muscular tendinous junctions, tendons, is because the PRP gives you the addition of platelets. And those platelets are really helpful because, as you know, they stick together once you inject them. And when they stick together, they form what's called a hemostatic plug. And that's really important because that hemostatic plug, it's like this massive stickiness, which really gives the stem cells like a place to go, a place to stick to, so that instead of them wandering away, getting lost, ending up someplace that they shouldn't, they essentially stick to that hemostatic plug and they stay in the tissue where they're important. Or another way of saying that is this hemostatic plug, which is provided by the platelets and the stickiness of those platelets, it really gives us a matrix or a scaffolding in which those stem cells can call home. And that's really important because that hemostatic plug, it essentially gives us a bridge or a scaffolding by which we can really use in a regenerative way to connect up maybe two different aspects of tissue that had been injured or torn or whatever, right? So if you think about a tendon or a muscular tendinous junction, I mean, if there was an injury there, like you've got to be able to piece those things together, right, in a way where it kind of bridges those structures in a way where that bridge then allows you to make the repair such that at the end of the day, we end up with one structure, right? So this matrix or this plug or this bridge, you know, if you want to fix a tendon or a muscle or the combination of the two can be a really, really cool thing. The other thing that's useful about adipose is, well, when you take the adipose mesenchymal stem cells and you add it with PRP, well, now you're getting both the addition of white blood cells, because usually PRP it has white blood cells in it, right? Like it's considered leukocyte rich, and we also know that we have all those platelets. And when I think about white blood cells and platelets, I kind of think about deployment packages for stem cells. And the reason is because we know that it's one thing just to inject stem cells, but stem cells are kind of dumb. Like they need instructions. They need to know, like, what are their marching orders? What do they need to do in the tissue when they get there? And the only way they know that is based off of intrinsic factors, factors that come inside of cells, or extrinsic factors, which are the signals that are outside of the cells, which are received by receptors on those stem cells, which essentially drive a cascade of events, which tell those cells what proteins need to be transcribed, because those proteins really dictate what the instructions are that those stem cells need to follow, right? So if you think about it, white blood cells have leukocytes, white blood cells have interleukin factors, white blood cells have cytokines, and platelets have a ton of different growth factors. And all of those things are the primary extrinsic signals or primary instructions to tell the stem cells what their job is going to be in the tissue, right? So for that reason, you know, it's not conclusive. They still use both BMAC and adipose-derived stem cells when it comes to tendons. But I would say at this point, there's a little bit more evidence for using fat stem cells. And the primary argument is we get a better matrix, a better scaffolding for the stem cells to actually sit and stay in the tissue, right? Or to bridge what needs to be repaired. And we get the combination of the platelets and the extrinsic factors that come in the leukocytes, which provide more instructions to tell those stem cells what to do. So at this point, you know, even though the literature is far from conclusive, when it comes to tendons, I would say that the literature leans a little bit more towards adipose-derived stem cells.
Thorough as always, Ray. I really love the analogy there of marching orders in regards to, they actually, they need to know what to do once they hit tissue and how they need to bond to that hemostatic plug.
For sure. I mean, I guess just to add one more point, about this matrix or scaffolding in class, I will often compare this to like the Jello that your grandmother used to make, where she makes it with the fruit that comes from the can, and then the fruit is kind of suspended in that jello. Like, it's almost the same thing when it comes to the matrix and the stem cells. Like, when it comes to adipose-derived stem cells, like, it gives us that jello, and then all the stem cells are kind of like the fruit, right? Where that can be a little bit disadvantageous, and one thing that I like to talk about when it comes to rehab, is that that matrix takes up space. And that's really important to say, because anytime that you take up any remaining space in the body, right, then essentially by taking up that space, you're adding pressure. And by adding pressure, you're creating an environment which is a little bit more inflammatory, right? Which is the reason why a lot of patients that have adipose-derived stem cells, like, not only do they have the extra matrix, which adds the pressure and the inflammation, but they also have a lot of leukocytes, which came from the PRP, which give you this additive inflammatory event, right? Which explains why patients that get adipose-derived stem cells can be a lot more uncomfortable as compared to, say, patients that get BMAC injections. Which is the reason why, from a rehab perspective, patients that get adipose-derived stem cells, say for a tendon injury, we need to spend a lot more time on the front end being able to manage that inflammation so that it's not excessive, and therefore we manage an environment which is optimal for those stem cells to proliferate and differentiate and to migrate and to do all the things that they need to do in order to optimize regenerative medicine.
Both of those inflammations are totally different. Inflammation that someone has from an acute injury versus the controlled inflammation that is being received from receiving procedures like this. And I agree that we need to control things on the front end of rehab, but also the back end of rehab. I always want to take it there. Let's dive into that a little bit more. Orthobiological hacker, we talk a lot about technology implication in regards to how we can help with, physical therapy and rehab, but also regenerative medicine. What technologies do you suggest for tendinopathy and tendon tears?
Yeah, so I always say in class, I think that there are really 4 technologies, according to the literature at this point, that are really the way of the future. Right? This is the stuff that, I'm not saying it's the only stuff, but at this point, it's the stuff that has the best evidence when it comes to rehab. And I would say that that's class 3, class 4 laser. You might even throw LED into that, right? It's shockwave. It's ARP wave, which you could say is multi-waveform technology. And then I would say hyperbaric oxygen. When it comes to tendinopathy and tendon repair, I mean, at this point, the thing that has the strongest and most consistent evidence across the literature is shockwave, for sure. I mean, hands down, when you're
That's
talking
what all our
tendons,
questions are about, is shockwave protocol for tendon. Yeah.
shockwave really does need to be part of the package. And I think what is the most interesting thing there is to ask the question, why? Right? And I would say it's because shockwave really gives us a 4-prong attack, which is important when it comes to repairing tendons. Number 1, you have to have angiogenesis. Number 2, you have to be able to get more tenocyte proliferation. Tenocytes are really just specialty fibroblasts that are associated with tendons. Right? 3, we have to be able to get those tenocytes or push them to do their job. And their primary job is really collagen production. And then 4, once we've actually repaired the tendon, we got to get that tendon back to homeostasis, right? We have to take away all remaining sources of inflammation and get it back so that it's able to do its job, whatever that is. And if you really look at those 4 steps, they best match with shockwave, right? So one of the coolest aspects of shockwave, and we talk shockwave, we could talk radial shockwave, we could talk focus shockwave. It is fair to say, though, when it comes to focus shockwave, we are able to consolidate the energy much better. and we can do it much deeper in the tissue, right? And those two things seem to be really important to tendons, which are usually deeper in the tissue and need consolidated energy, right? So usually you think it more focused shockwave as compared to radial. But honestly, the beauty when it comes to focused shockwave is angiogenesis. Really, it's all about angiogenesis. How does focused shockwave give us angiogenesis? Now that's interesting, right? So we know that when it comes to shockwave, in the main, it's all about being able to use mechanotransduction in order to activate a cascade of events that gets us transcription factors that allows us to transcribe the parts of the genes that we need in order to create the repair. In the main, those cascade of events are the ERK pathway and the AKT pathway. And the transcription factors that those cascades give us in the main are AP1 and NFK beta. Those are simply transcription factors that allow us to turn on certain parts of the gene so that I can transcribe them into the proteins that I need to get the job done. Well, I'll tell you, the first thing that shockwave really does in terms of transcription is it transcribes what are called matrix malase proteins. Matrix malase proteins are really cool because I often will say that they're almost like little Pac-Mans. We make these little Pac-Mans, we dump them out of the cell after we make them. And so now we have these little Pac-Mans that live in the extracellular space. And much like Pac-Mans, they do their job and they chomp around the area outside of the cell, right? And they essentially cause damage. They are the number one reason why, when it comes to shockwave, one of the primary steps that is caused is actually inflammation. It's an inflammatory step which allows us to get to angiogenesis. Why? Well, think about it. The only way that I can make new blood vessels is if I have the room or if I have the space to actually lay down those blood vessels, right? Or another way to think about it is if you want to repair anything, like imagine the kitchen in your house. You can't just bring in all of the new cabinets and the new refrigerator and the new stove into your kitchen and just replace it. No, the first thing that needs to happen is the demolition crew. You got to go in there, you got to break everything down with a hammer, you got to drag out the old refrigerator before you can actually make the new, right? So we got to make the Pac-Mans, which essentially turn the extracellular space, the area around the cells, into Swiss cheese. And then if you think about all of the holes of the Swiss cheese, those holes then actually give me the space such that when I make new blood vessels, that I can lay those blood vessels down into those holes in and around the cells to be able to drive the repair. And that's a really cool thing to think about because, right, like new blood vessels is almost like the scaffolding that they put around buildings before they repair the building. Like you got to have a pipeline that's able to deliver oxygen, raw materials, white blood cells, enzymes, whatever it is that you need to deliver to the guys that are fixing the tissue where the tissue needs to be fixed. So that pipeline of all these new blood vessels, it gets us everything that we need in order to be able to repair the tissue. That's got to be step one. Step two then is, well, we essentially use the very same cascades to transcribe, to give us transcription factors to transcribe the parts of the genes that we need for angiogenesis. Well, I will tell you that the number one transcription factor, aside from just AP1 and NFK beta, that you get from the ERK and the AKT pathway is something called HIF1 alpha. HIF1 alpha is a transcription factor that is primarily associated with hypoxia, which comes from tissue damage. And HIF1 alpha is really, really important because it's one of the primary things that we're going to need in order to create VEGF, which is vascular endothelial derived, I'm sorry, VEGF, which is vascular endothelial growth factor. One of three things that we need for angiogenesis. The second thing that we're going to transcribe via AP1 and NFK beta is something called transforming growth factor beta. Transforming growth factor beta is then kicked out of the cell, and it's recognized by receptors for transforming growth factor beta. And when that happens, transforming growth factor beta is able to then talk to the cell that just made it by producing something called SMAD3. Here's what's cool. SMAD3 then goes to the nucleus and it gets together with HIF1 alpha. And then together they work additively to transcribe the parts of the genes that give us VEGF. VEGF, vascular endothelial growth factor, is the orchestrator of angiogenesis. It is one of three things that we need to make new blood vessels. But the show's not over. Because then what happens is the very same ERK pathway and the AKT pathway, which we turned on by doing shockwave, right? Then those guys are going to transcribe something else, nitric oxide synthase. Nitric oxide synthase is the primary enzyme that's responsible for converting L-arginine into nitric oxide. And you know that nitric oxide is the #1 vasodilator in the body, and it's the very thing which is going to control the blood flow, the hemodynamics that we're able to put into the new vessels once those vessels are laid down in the right way by VEGF, which means that nitric oxide is the #2 thing that we need for angiogenesis. But the show's not over. Because the third thing that we transcribe via AP1 and NFK beta is something called SDF1. SDF1, it works via a chemokine gradient to essentially beacon or to call the stem cells from both the bone marrow in the main and even from the fat to report to the area to actually be able to then turn into the cells that we need to make new blood vessels. So now the stem cells that I'm talking about now aren't necessarily mesenchymal stem cells. Now what I'm talking about is hemopoietic stem cells and endothelial-derived stem cells, which actually make up the building blocks or the structure, right, of the new blood vessels that is being coordinated by VEGF, right? And then the nitric oxide is then sending the blood flow into those new blood vessels so that it's the trifecta. I get the new stem cells called to the area by SDF1. I get the new blood from the nitric oxide, and I get the orchestrating of the laying down of those vessels via VEGF. Those three things essentially give me all of the new blood vessels with the new blood and everything that comes from that blood, right? Which is now growing in all of the holes of the Swiss cheese that came from that initial inflammatory event. Once I have angiogenesis, now the actual repair can begin. And now what happens when we do focused shockwave is now we begin to drive the proliferation of the very cells that we need to make new tendons. What are those cells? Tenocytes. The literature is clear. When we do shockwave, we cause a significant increase in the proliferation of those tenocytes. We start to get the production of way more tenocytes than what we had before. And once we have those tenocytes, we use the very same focused shockwave to push those tenocytes to do their job. What's their job? In the main, it's to make collagen fibers. And not just any collagen fibers, type 1 and type 3 collagen fibers, because we know type 1 collagen fibers give us the strength of the new tendons, and type 3 collagen fibers give us the flexibility that we need in those new tendons, which ultimately give us the physical properties of what we need those new tendons to be. So if you think about it, new blood vessels first, new cells to make up the tendons, new type 1 and type 3 collagen fibers from the tenocytes to make those tendons be able to do what we need them to do. Final step, which shockwave gives us, is now we need to return to homeostasis. We got to take away any additional inflammation in that tissue so that now the tissue is finally back to normal. And what we know about shockwave is, just like shockwave gives us an initial inflammatory event, shockwave also on the tail end helps us to take the inflammation away. And they do in the main one of two ways. They use toll-like receptors to change the calling of M1 macrophages to M2 macrophages being called to the area. That's important because while M1 macrophages release cytokines associated with inflammation, M2 macrophages are anti-inflammatory. And we know that shockwave is able to decrease any peripheral C fibers that had been upregulated due to the initial pain or injury in the periphery, particularly in the connective tissue structures, making it so that all of those additional C fibers or those additional peripheral nerve endings, instead of them being excessive because of that pain-related event, that they're now going to come down in number, approaching what is now normal. That's important to say because we know that all of those additional C fibers that had been upregulated are primarily responsible for delivering CGRP and glutamate from the periphery centrally. And in doing so, they drove inflammation and thereby pain. As the number of those pain fibers now approach normal, that essentially means that we have an appropriate amount of inflammation in the periphery, such that now we've now achieved homeostasis, by which that tendon can now go back to doing its job in a functional way. There is only one technology at this point that gives us all four of those steps in a way which is significant, in a way which is exaggerated, and a way which is temporally correct, which is conducive to the repair of tendons. And that's shockwave.
Wow. Shockwave, angiogenesis, tendon repair. Love
Huge.
it. I feel like you're setting me up there, Ray, to ask about what stimulates M1 and M2 macrophages. But I absolutely love the fact that it's a difficult concept to wrap around, using shockwave to reduce inflammation. But I think you explained that really well. It's an incredible technology. But I want to keep going here. I want to stay on tendons, stay on the same topic, but I want to bring a little bit of a different thought to the equation here. What about calcific tendinitis?
Yeah. I get this question a lot on courses too. And this is another reason why, like, you really have to understand the physiology of focused and radial shockwaves so that you can really make the right decisions as to how you're going to do it in the clinic, so that you can do it in a way which is most appropriate for the problem, right? And so when you compare, just tendons and tendinopathy and then calcific tendinitis, those are two unique problems. And so there really have been a number of studies in the literature, and I'm talking like systematic reviews at this point, that have really asked the question, like, when it comes to calcific tendinitis, what's important? How can we best use shockwave in order to get to outcomes? And the short of it is really two things. When it comes to calcific tendinitis, focused shockwave is significantly better than radial shockwave. I know I said that before in general, just about tendons, but it's exaggerated when it comes to calcific tendinitis. Because now not only do I need to be deep where the tendon normally is, but now I need enough consolidated energy at the place of the calcification to be able to get the desired effect, which is to get rid of the calcification. So across the board, it shows that focused shockwave kicks butt as compared to radial shockwave. And the second thing is that, as you might expect, when it comes to calcific tendinitis, like, dose is everything. Like, dose is super important. I mean, it's normally important, but calcific tendinitis, it's crazy important. Like, now we're talking about more on the high end of like moderate intensity shockwave, or maybe even a little bit like higher intensity shockwave. Like, you have to be able to have enough dose, which provides enough energy, which then you can in turn consolidate at the place that's important in order to treat calcific tendinitis. So you can do it. It's absolutely evidence-based when it comes to shockwave, but the dose has to be adequate, and focused is better than radial.
I mean, it's called focus for a reason, right?
Sure.
Let's say I'm a clinician that only has a radial shockwave, you think it's worth my time?
I think it depends on the tendon. So if it's only a tendinitis, or some sort of a tendinopathy, or maybe you have some sort of a mild tear, if it's superficial, yeah, I think you got a shot. Like, if we're talking about like a supraspinatus tendon, right? But if it's something which is considerably deeper, like we're talking about the internal and external rotators of the hip, right? Or we're talking about, I don't know, something where you're going to need some centimeters to actually get there, I think radial is a hard sell.
Gotcha.
And then if you're really talking about calcific tendinitis, well, then I think you really don't have a sell for radial shockwave at all. So it's not that radial is wrong or bad. It's just that you never really consolidate the energy, right? And it is very difficult to get enough energy to be able to have the desired effect deep down in the tissue where you often need it for some of these tendon-related problems. So, I would say if you do get focused shockwave, consider that the highest dose of radial shockwave is almost the lowest when it comes to focused shockwave, right? And if you use focused shockwave in a way which is more comprehensive, you use it and you keep it where it's needed, but you also move it a little bit and you're treating multiple structures, it is easy to make the argument that you could use focused shockwave in a radial way. But what it's hard to say is that you can use radial shockwave in a way that is focused. Gotcha. So what I'm saying in a nutshell is focused shockwave is just going to give you a lot more power in order to be able to treat more and different types of conditions where you're going to be more limited when it comes to radial shockwave.
Fair enough. Okay, let's keep talking about tendons here. I want to keep things rolling. I want to dive a little bit more into physical therapy and rehabilitative space. What's the thing that we all do? Exercise, right? I have seen, 10 years ago is the hot eccentric phase of all things tendons, but now are we going more concentric now? Oh, what's going on in the literature here, Ray? Where do we stand when it comes to concentric versus eccentric, isometric exercise with patients and tendons?
Yeah, it's frustrating, isn't it? I mean, what I learned in school, I think it's the same as you, when you've got a tendinopathy, a tendinitis, usually we would say that is caused by an inflammatory event, which is driven by concentric movements. And so in order to be able to maintain the strength and the loading and the restructuring of that tendon, we need to be able to do it, but we really need to focus more on eccentric so that we don't have the same inflammatory event caused by that initial concentric movement, right? So it's the reason why, like, when it comes to these tendon-related problems, we have always focused therapeutically more on eccentric exercises as compared to concentric exercises. What I will tell you is that over the past few years, if you look at the literature, that the best studies are now suggesting that maybe the best thing that we could do for some of these tendon-related problems is both. So it's actually incorporating both eccentric and concentric loading into tendon repair, which actually gets you the best results, particularly in medium and long-range outcomes, right? So now, I do think that it is fair to say, according to the literature, that perhaps using eccentric exercise in the beginning, if the patient is more acute, makes more sense. And then as time goes on, working more towards concentric exercises, or ideally concentric and eccentric exercises. But the point is, concentric exercise or concentric loading is not taboo when it comes to tendinopathy and tendon repair,
I feel like for a lot of
like
people
it
it
used to
is.
be. What's that?
I feel like for a lot of people it is still.
I think if you time it correctly, then I think what you're seeing is that the best of both worlds is where it's at.
And I
Now,
can definitely get behind that, even from not even just from a physiology standpoint, but from a re-education standpoint, when it comes to, getting someone out of pain to then go into the concentric motions that put them there in the first place.
exactly. I mean, at the end of the day, when it comes to tendons, what we know is that they need to be loaded, eccentric or concentric. Like, they have to be loaded in order to push the tendon to make new cells, right? In order to drive the repair. And then, even more important, they have to be loaded so that we remodel the tendon in a way that is functionally appropriate, right? And the way that we load it needs to be specific for the angle, the original job of that tendon, so that as we remodel that tendon in terms of the collagen fibers, that we do it in a way which is functionally appropriate, right? So hands down, like, it has to be loaded. Like, you just doing manual therapy, you just using technology is not going to be the best thing when it comes to tendons. Like, exercise, as with most of what we do, needs to be part of the picture. When it comes to tendons, I think it's even more exaggerated, right? So the point is physiologically, we got to do it, right? But how we get there, it seems that the combined effect of both eccentric and concentric is important. When we do those things, I think is a fair argument, maybe eccentric before concentric. But at the end of the day, the reason why I'm saying that ultimately is because it needs to be graded. It needs to be done in a way which never drives too much pain and therefore drives an inflammatory event. Because if it's too uncomfortable and now you are driving inflammation by loading it, that inflammatory event is going to be counterproductive to the overall repair of that tendon. And that's usually where we get into trouble. Too much, too fast. And that's important to say, and I say it a lot on our orthobiologic hacker certification series, is because this is the time to maybe think about, all right, well, what could we do then in order to augment exercise to make sure that we actually get the dose correct, to ensure that we actually grade it in the right way where we still get the job done, right? But we never push the tendon too much to drive inflammation and then be counterproductive, right? And if you think about it like that, well, maybe two things to think about to optimize loading would be blood flow restriction and multi-waveform technology. I mean, honestly, I think these are the two things that are game changers when it's come to physical therapy. Certainly, they're a big part of what I do in clinical practice. Um, both are fantastic. I would say one of the primary arguments against blood flow restriction, not that it's bad, and certainly there's emerging evidence when it comes to tendon repair, but something to consider. It's the ultimate example of causing muscle hypertrophy or even tendon strengthening without the neuromuscular reeducation. In other words, if you think about strengthening a tendon or a muscle, the first thing that we always need to do in the first, 4 to 6 weeks, it's all about getting the nerves to work better with the muscles at the neuromuscular junctions. That is, we need to change the motor units to improve the efficiency, right, before we get to the hypertrophy. And when it comes to blood flow restriction, it seems to work like a champion, but it's almost like we skip the neural aspect of that and go right to the hypertrophy strengthening stage, right? Which is why in some patients, I like to think a little bit more about multi-waveform technology. So multi-waveform technology, there's a couple different versions of that. I know we like to talk a lot about ARP wave. And the best way to think about ARP wave is imagine if you could take NMES, FES, low frequency tens, high frequency tens, interferential current, microcurrent, and then throw a little KFAC into the mix, take the best aspects or the best qualities of all of them and put them together into one thing. I mean, imagine being able to use the NMES part and being able to stimulate the muscle at the muscle, but use the same electricity to stimulate the axons of the alpha motor neurons, and therefore, in real time, be able to drive the plasticity, which gets us neuromuscular reeducation at the neuromuscular junctions, with the overall activation of satellite cells and hypertrophy of the muscle. And then do it by also stimulating supraspinal activation, which gets us a reinforcement and better feed forward activation of the central nervous system to the muscle, right? And then be able to do all that while providing high frequency and low frequency tens so that you could get the patient to actually move their body in a way which is optimally pain-free. Maximize that pain-free range of motion that we want to be able to exercise, and thereby get rid of any source of pain inhibition or any protective strategy by which maybe we get some hypertonicity of muscle. I mean, it's one thing to move and exercise. It's another thing to be able to move and exercise without pain, qualitatively, right? And then be able to do all of that, not just on the surface of the skin, but to use interferential current with the NMES and the TENS and use it as a carrier to get down deep inside the tissue to the parts of the muscle where the neuromuscular junctions are that actually need to be fixed and repaired, where we really want to create the change, where the problem really is deep in the tissue. And then be able to combine that with the microcurrent such that in between everything that I just described to you, we can always come back to microcurrent, which keeps the tissue that we want to fix in an optimal state of repair. I mean, if you think about it, it's the ultimate way of maybe bringing the sexy back to exercise, or in the world of tendons, right? In the world of tendons, ensuring that not only are we loading those tendons in a way which is appropriate, but we ensure that we're able to do it in a way which is dosed appropriately so that we never accidentally drive an inflammatory event. We never overdose it and do too much too fast, right? Because if you think about it, when it comes to blood flow restriction or when it comes to multi-waveform technology, by using these technologies as a way to augment exercise, I don't have to load it as much as without. I could do a 20 or a 30% maximal voluntary contraction, keep the tendons safe, still get the same point across, but never risk loading it so much that I do too much too fast, or I accidentally drive inflammation and therefore take 2 steps forward and 3 steps back, right? It's almost like, what are the technologies that we could use which match the physiology of the repair so that we could up our game to ensure that what we are doing fits physiologically with the repair process of tendons.
And if you do color outside the lines a little bit, angiogenesis, shockwave, stimulate the macrophages, reduce the inflammation. I mean, what you're talking about, I imagine like you've got all these different levers that you can pull, right? And like I need to progressively load more and more and more, but like, okay, I need to reduce inflammation because I'm loading too much, or I need to improve the neuromuscular re-education, or maybe hypertrophy is more of the component, or that's not as bad. I need to really make sure I'm stimulating the nervous system. You've got, what you're talking about is multiple levers that you can pull based on your specific patient and what's going on.
It empowers clinicians, regardless of the profession that you're from. It gives us more options to be able to do more things and pull more levers so that we can actually up the game on rehab. We can make what we do have better value. And then with that better value, right, then we're going to earn the ability to do more things, play a bigger role in the overall rehab of the patients that we see. And ultimately, I want us to earn the ability as rehab professionals to be able to even do more things than that as part of what we do. Because if we can do that, we should eventually get to the point where we could expand our scope a little bit, see more patients, different types of patients, be able to treat more problems so that ultimately we can use some of these different ways of thinking and some of these different technologies in order to become the standard of conservative care.
We are all about top of scope here at Torrentia.
So I hope, I know that was pretty detailed. Maybe more than what you wanted. I will tell you guys that I am all about the details because I think as a doctoral profession, whether you're a chiropractor, physical therapist, whatever, like we need to start having that level of an understanding because this is our business, right? And if we're going to make the right decisions in the clinic, we have to understand the how and the why of what it is that we do. Right. And if you come to class, I promise you, I will go through all the things that I talked about with pictures and diagrams, and then it's a little bit easier for me to kind of lead you through it and tell the story. Right. But ultimately, I really feel like I'm going to be able to explain to you guys what's going on here and why these technologies are so amazing and how they can really transform your practice and change the paradigm in which you operate. So that, at the end of the certification, you're not going to go home with 1 or 2 different skills, or new tricks to try, but you're going to go back to the clinic an entirely new therapist. And that's the point. All we really want to do at Torrentia is be able to change what it means to be a rehab professional so that we can finally have all of the outcomes that we always dreamed about in PT school or chiro school or athletic training school or whatever it is, so that we can finally be able to make the impact that we've always wanted. So I hope you guys will at least take a look at our courses. I talk about this in the orthobiological hacker course. Obviously, when it comes to regenerative medicine, we talk about it in the advanced specialty practice course. But I really would like to open your eyes to what I think is the future and to what I think is possible for us.
Ray Butts, Tendons, Torrentia Medical Education. Thanks so much for your time, man. I really appreciate it.
Thanks for having me.
Take care.